Welcome to the Tuesday, March 7th meeting of the Tri-Cities Prostate Cancer Support and Awareness Group. At this meeting, we're welcoming Dr. Silvia Chang, who is speaking to us about prostate MRIs, how they can help. Dr. Chang is a radiologist at Vancouver General Hospital, VGH, and University of British Columbia, UBC Hospital, where she is the section head of abdominal imaging in the Department of Radiology. She is an associate professor, vice chair of professionalism and wellness, the Abdominal Imaging Fellowship co-director in the Department of Radiology, UBC. Dr. Chang completed her medical degree and her diagnostic radiology residency at UBC and her abdominal imaging fellowship at the University of California in San Francisco. Following her fellowship, she returned to Vancouver to become a staff radiologist at VGH and established the abdominal MRI program there. She helped establish the Prostate MRI US Fusion program at VGH in collaboration with the Department of Urological Sciences and initiated and co-chairs the MRI Prostate Tumor Conference. Her area of expertise is abdominal imaging, particularly prostate MRI, with multiple publications and invited presentations at local, national, and international meetings. She is a fellow of the Society of Abdominal Radiology, fellow of the Canadian Association of Radiologists, founding president of the Canadian Society of Abdominal Radiology, and sits on the executive board of the BC Radiological Society. Now, due to a recording problem with this meeting, we joined this meeting after Dr. Chang's opening remarks and after she presented an outline of the topic she was to cover. My apologies for failing to properly record the first minute of Dr. Chang's talk.
Lumps or masses arising from your prostate gland. So it's nice and then bright. It's called hyperintense on MRI. So that's the purple zone, and the majority of cancers occur in this area, about 70%. Then you have what's called the transition zone, which is depicted by the arrows in green, and you can see it has more of kind of a gray area, a gray look to it, and that's a normal transition zone. And approximately 20% of the cancers occur in this area. And this is a zone that gets enlarged. When you hear about the term BPH or benign prostatic hypertrophy, it's this zone that gets enlarged, and you can see it's kind of surrounds the urethra. You can see how if it gets big, it can kind of compress the urethra and makes it difficult for you to empty the bladder. The other zone is what's called the central zone, and it kind of sits between the peripheral zone and the transition zone. So it's kind of in this area, and about 10% of cancers occur in this region. Okay, so this is what normal prostate MRI looks like. Now, in the 1990s, there's further refinement of the images, and we had some standard sequences, what's called T2 and T1. In the 90s, MRI was primarily used for staging, local staging, to find out if the tumor is confined within the prostate gland. In that case, surgery is probably the best treatment option. Or if it's spread beyond the gland, in that case, perhaps surgery is not the best option, and maybe radiation therapy would be more appropriate. So this is what prostate cancer looks like on MRI. It's seen as a dark spot. The medical term is hypointense. So this red arrow is prostate cancer. And what you can see here is that it's spread a little bit beyond the capsule. So this is the border of the prostate gland. You can see it's gone beyond it. And this is another view. This is a coronal view. Remember, we talked about the frontal view. So here's a tumor, and it's gone beyond the prostate gland. So this is T3 disease. So this would be more appropriately treated with radiation therapy rather than surgery in general. All right, so we talked about the T2 weighted sequence. It's the one where we can see anatomy, which I've just shown you. And you can also see the structures adjacent to the prostate gland to see how far the tumor may have spread. You can look to see if there's seminal vesicle invasion. So the seminal vesicles sit on top of the prostate gland and help to produce fluid that's in the semen. And usually they're kind of bright on T2, but when there's invasion from tumor, it becomes dark, as shown by this yellow arrow. MRI can also look to see, as shown in the prior case, but also in this case, you can see that this is the cancer. It's dark on T2, and you can see it's spread beyond the prostate gland and is actually surrounding the nerves and blood vessels. That's what we call extraprostatic extension. In addition, it can also look to see if there's any spread to the adjacent lymph nodes. So these rounded areas or oval areas are lymph nodes. And the medical term for lymphadenopathy means abnormal lymph nodes. And usually abnormal is because they unfortunately are bigger than expected, and that's concerning for spread to the lymph nodes. So this is where MRI can be helpful in staging. So as technology improves with MRI, in addition to the T2-weighted sequences, there's been development of new sequences. And with these new sequences, we're able to actually detect prostate cancer and localize to where it could be, kind of give a score of how suspicious we're about, how suspicious the lesion could look. And also if you undergo treatment, we can also use MRI to monitor to see if the cancer could be coming back or not. So when we talk about multiple sequences, you might have heard the term multiparametric MRI, which means there's multiple sequences in addition to the traditional standard T2-weighted sequence. If you look at this T2-weighted sequence up here, you can see that the tumor is hard to spot. It kind of blends in with the rest of the gland. And sometimes that happens. However, with these new sequences, what's called DWI stands for diffusion-weighted imaging, which is the sequence down here. And then ADC, which stands for apparent diffusion coefficient, which is the sequence here. You can see that there's a dark spot up here and there's a bright spot up here, indicating an area that's suspicious for cancer. So how does this sequence work? Well, diffusion is as the word says, it has to do with assessing diffusion of the water molecules in soft tissues. So if you kind of remember your science 11 or science 10, you know that water molecules diffuse out in the tissues, as shown here. The water molecules, these pink dots with the green ears, kind of like your H2O molecule, they just move in random directions. Now, if you have cancer, usually you have more cells. If you have more cells, there's less space for the water to move around. And so your movement is restricted. So it's called restricted diffusion. And MRI is able to pick up restricted diffusion. So here's a spot with the restricted diffusion. It's bright on the DWI and it's dark on the ADC. You do want both of those sequences available because what can be bright on DWI, unfortunately, sometimes can be a false positive. And what's dark on ADC alone, again, can be a false positive, not represent cancer. You actually want to see restricted diffusion both on the DWI and the ADC to say for sure you have restricted diffusion. Okay, so the ADC map comes with the DWI. It's a post-process image from the DWI. The other sequence is contrast. You might have heard about contrast being injected into the vein. And this is what contrast is used in MRI. It is injected into the vein. And then we scan repeatedly to see how the tissues behave and how well it takes up the contrast agent. So tissues in general will pick up some contrast, but areas of cancer need more of the blood supply and will pick up more contrast. So as shown here, contrast is usually bright on MRI. So you see this kind of white spot. You see it's brighter than the rest of the gland. Well, that indicates an area that's concerning for cancer. So these new sequences have really helped in detecting prostate cancer. So we moved beyond staging. We can now use MRI to help detect prostate cancer. And with the improved technology, it then obviously progressed to where we standardize how we acquire the imaging and how we interpret it. It makes sense now that there is this demand and utility for prostate MRI. We should have some uniformity in how we perform and acquire the images, and also the same sort of terminology as how we report it. And that's where Pi-RADS has been developed. And it was first published almost 11 years ago, around this time of the year in 2012. We're now into the third version, which is called Pi-RADS 2.1. So we had Pi-RADS 1, and then in 2016, we had Pi-RADS 2, and in 2019 was the latest update, which is Pi-RADS 2.1. What's also happened towards the end of the 2010 decade, we found that MRI has been useful in detecting prostate cancer when we do the MRI up front before the biopsy. So some of you may have had the biopsy first and may not even have needed an MRI, or had the biopsy first and then had an MRI to stage, But the studies and research have shown that actually, if you do the MRI before the biopsy, you're going to have a better rate of picking up clinically significant cancer. So that's a new standard now. Rather than just getting the biopsy first, you're getting the MRI first, because the MRI can help direct you where to obtain the biopsy. And because the MRI can direct you to where to do the biopsy, we've now moved on to what's called MRI targeted biopsies, where the MRI shows you where to perform the target. And when you aim for the target, you can do it in several ways. In some places, you can actually do biopsies in the MRI scanner. Unfortunately, in this province, we don't have that capability at this point, but some places have that capability. You can do what's called cognitive biopsy, where, for example, I see that the tumor is, in the left side and the bottom part of the gland, then I know to biopsy that part of the gland. Or you can do it by fusion biopsy, which is what I'll show you in a few minutes here. So what does Pi-RADS stand for? It stands for Prostate Imaging Reporting and Data System. And it does have assessment categories for the likelihood of clinically significant cancer to be present. And it ranges from a Pi-RADS score of 1 to 5. So a Pi-RADS 1 score means very low likelihood of clinically significant cancer to be present. Pi-RADS 2 would be low likelihood of clinically significant cancer to be present. And Pi-RADS 3 would be intermediate likelihood of clinically significant cancer to be present. Pi-RADS 4 is high likelihood, and Pi-RADS 5 is very high likelihood of clinically significant cancer to be present. And just kind of review what clinically significant prostate cancer means. So as you know, you might be familiar with Gleason scores, and also there's a new grading system called the International Society of Urological Pathology grade group that also grades it from 1 to 5. So Gleason 3+3 prostate cancer usually undergo active surveillance, whereas the Gleason scores greater than that tend to undergo treatment in general. Though I do know that some patients who have small volume Gleason 3+4 may opt to undergo active surveillance. Okay, but in general, most 3+3 tumors can undergo active surveillance. So let's go over the Pi-RADS report. I did receive some feedback that you want a better understanding of what does this mean. So this is a template that's recommended.
Excuse me for a moment. Could we just, sure. Whoever just joined us, could they mute themselves, please? We're having difficulty hearing. Govinda, can you mute yourself, please? Thank you.
So the Pi-RADS template, well, first of all, its indication, like why you're having this prostate MRI. Is it because your PSA is elevated, because it's climbing, or are you looking for question recurrence? And then the technique, you want to confirm that you are following the Pi-RADS specifications with the type of sequences that are required and how you also acquire the sequences, and whether you use contrast or not. If you're imaging on a 1.5 magnet or 3 Tesla magnet, there are different field strengths for MRI. And the comparison is always helpful. Usually we do record the size of the prostate gland and also the quality of the study, because if it's a poor quality exam, we know that it can be difficult to assess whether there's a prostate cancer there or not. It's always good to look to see if there's hemorrhage. Sometimes you get the MRI after the biopsy, and sometimes you can have a bit of hemorrhage because of the biopsy, and it can actually make interpretation a little bit challenging because hemorrhage can mimic prostate cancer. So it's nice to know to see if there's any potential sites of hemorrhage. And then we move on to look at the anatomy. So we talked about the peripheral zone where most of the cancers occur and the transition zone. So these are the two zones we look at carefully, and there's different ways to analyze the two different zones. When we do see a lesion, we do mention where it is. For example, is it the right side? Is it the left side? Is it a base, midgland, and apex? Some of you may know the base is actually the top third of the prostate gland, then the midgland is the mid third, and then the apex is actually the bottom third of the gland. It's also important to know the size of the lesion. and then what the score is on T2. So there's criteria to determine what the score is on T2, what the score is on diffusion weighted imaging. So now you know what that sequence is all about, and also dynamic contrast. And then based on these three scores, you get an overall score. In addition to the overall score, the urologist wants to know, is there any involvement of the adjacent neurovascular bundle? Is there any evidence that the cancer has spread beyond the prostate gland? Which we can also mention down below in the template. If there's any invasion to the seminal vesicles, do we see any enlarged lymph nodes? And how are the other structures? We also see the bladder, we can also see the rectum, we can see some of the pelvic bones as well. So we comment on that. And then we give our overall impression if there's any lesions and the overall suspicion of the lesion. Okay, so this is the Pi-RADS report. So this is just an example of how we kind of go through, how we would go through a report. So this, again, we have the axial T2, we have the diffusion weighted sequences down below, and we have the contrast. So when we review prostate MRI, it does take a bit of time to go through all the sequences and look at all the criteria to give a score. And so when we look at the T2 or the peripheral zone, there's certain criteria to give it a score. So in this case, this would be a score of 5 because we see this lesion that is demonstrating extraprostatic extension. Okay, so we have a lesion. So it's not totally normal. Normal would be 1, like the initial image I showed you earlier. This definitely is there's a dark spot in the peripheral zone and it's spread beyond the gland, so it becomes a score of 5. Then we move on to diffusion weighted imaging to see how that looks. So we see an area of restriction, see it's bright, and then it's dark on this sequence and looks like it's spread beyond the gland. So this becomes a score of 5. For contrast, it's a little bit easier to score. It's either enhancing or it's not really enhancing. In this case, you can see that there is some enhancement here. So then this would be a positive. The overall score is based on the diffusion weighted in the peripheral zone. So the overall score of DWI here is a 5, and therefore the overall score is a 5. So this is a Pi-RADS 5 lesion. So it means it's very suspicious for prostate cancer. So does a Pi-RADS 5 always mean it's cancer? Not necessarily. This is a review of 17 research articles, and they found that when they looked at 1,946 lesions in 1,268 patients, they found that there is obviously a low likelihood of cancer when you call something normal, so very, very low. But as you get higher to Pi-RADS 5, you get a higher likelihood of cancer, but it's not 100%. Okay, so in general, the higher categories are associated with higher cancer detection rate, but it's not 100%. So a Pi-RADS 5 doesn't mean you automatically have cancer, but certainly you have a high chance of it. A Pi-RADS 4, ranges from 50 to 59%. A Pi-RADS 3, which is equivocal, the chance of cancer is relatively low. It's actually less than 50%. So in general, if you get an MRI and reports a Pi-RADS 4 or a 5 lesion, there is a higher risk of prostate cancer. And usually you and urologists would have a discussion and probably would recommend undergoing a prostate biopsy. If you have Pi-RADS 3 lesion, you can see that the risk is lower. May not go to biopsy. It depends, I guess, on the risk, and may decide to hold off and maybe see what the PSA is doing, or perhaps get a follow-up MRI. You may not need to go to biopsy. But in general, if you have a Pi-RADS 4 or a 5 score, you tend to go to biopsy. So MRI, as you can see, is not perfect, but at least it kind of gives you an idea of, if you see a lesion, the likelihood of cancer, and it does seem to correlate with basically the score. The higher the score, the more likelihood of cancer. But just be aware that just because a prostate MRI is normal, we don't see a lesion, doesn't mean that there isn't cancer there. sometimes we just don't see it on MRI. And that happens about 15% of the time. Depends what article you read, what research paper you read. It can happen 11 to 15% of the time. So if your MRI is negative, that doesn't mean you don't have cancer. That's something you would have to discuss with your urologist as to, how worried are you both are, what's the risk, and you may decide to go to biopsy anyways. Okay, so this is another MRI, and this is a patient who is 62 and he had a rise in PSA, a PSA of 10.8. That's pretty high. And even with the high PSA, he had a biopsy that was negative. And the reason why it was negative is because most of the biopsies are obtained from the posterior portion of the prostate gland. And the tumor is actually anterior, so we could see why this was missed. And this is where MRI is helpful. If you have a negative prostate biopsy and your PSA is high and you and your urologist are still worried, MRI can help to see if there's a lesion that may not have been targeted on biopsy, and that's what happened here. So in the transition zone, we would give it a score of 5 because it's homogeneous, but it's greater than 1.5 centimeters. So that'd be a score of 5. With restricted diffusion, I would give it a score of 3 because it's a bit dark, but it's not like much darker than this area. And same thing, it's not much brighter. It's not the brightest lesion compared to the rest of the image. So I'd give it a 3. And then for contrast, yes, I would give it a positive. This part is lighting up better than this part. This is a normal gland. You can see it's not really lighting up as well as that. For transition zone, the T2 edit sequence is a dominant sequence. So you go by what's on the T2. For T2, we give it a score of 5. So it doesn't matter what happens on DWI. It doesn't matter what happens with contrast. If you give it a score of 5 on T2, it becomes a 5 overall. So this is where MRI was helpful in this patient. He had a negative biopsy, and MRI was able to identify a lesion anteriorly that was missed on biopsy. What we can do is then make a note of where this lesion is on this schematic diagram. So it was in the top part of the gland, so that's the base. The mid part is the midgland, the bottom part is the apex. You can see it's kind of like an inverted cone or kind of like an acorn where the apex is the smallest part, the bottom part. The lesion is in the right base, right here. So this kind of helps to direct whoever is performing the biopsy to know where to aim to take the biopsy, because lesions can be difficult to see on ultrasound when we take the biopsy. So we have what's called MRI ultrasound fusion biopsy system, where on the MRI, you localize where the tumor is, and you have a registration system where we'll overlay the ultrasound with the MRI so that you know where to target it on ultrasound. Because on ultrasound, it may be difficult to identify. So it tells you where to biopsy on ultrasound, and you take the target. And this patient ended up with Gleason grade 3+4, involving the majority of the biopsy, 70-80% of the core. So he went on to treatment for his prostate cancer. Okay, and this is another system again, where this is an MRI image below, which shows a lesion in the right side of the prostate gland. You can circle the gland, circle the lesion, and then the software program registers it onto the ultrasound, and then it directs you to where to aim, because on the ultrasound, you can't really see it that well. MRI, you can see it, and then you take the target. So why do it this way? Well, if you do it by MRI, unfortunately, we don't have that equipment. If you do have that equipment, it does take a fairly longer time to obtain the biopsy, whereas ultrasound it's quicker to do. So that's why we use the fusion system, because we don't have the MRI availability, and we also have ultrasounds readily available, and we have the fusion system to register the abnormality. Okay, so then now currently moving on to the 2020s, we now have developed a system to assess treatment. So patients who've undergone prostatectomy and radiation therapy, there's a way of monitoring treatment and having a unified kind of way of acquiring these images and how we report it. We're working on active surveillance and screening, and just touch briefly on artificial intelligence. So that's where we are in terms of the research that is happening. So prostate imaging for recurrent prostate cancer uses the Pi-RADS system, which stands for prostate imaging for recurrence reporting. And with regards to recurrence, it is suspected when you have what's called biochemical failure or PSA rises. And this occurs in about 27 to 54% of men, so quarter to half of men. After radical prostatectomy, the definition is if you have 2 consecutive PSA levels, more than 0.2 nanograms per mil. If you had radiotherapy, the definition of biochemical failure is if your PSA increases greater than 2 nanograms per mil, higher than your initial PSA nadir, so higher than your initial lowest PSA level. Focal therapy, some of you may be familiar with this. We don't offer this in the province of BC, but some people go away to have HIFU, which is high intensity focal ultrasound. There's also different ways like cryotherapy, where you focus the treatment to just a particular area of the gland, the area that you see the cancer and the lesion rather than the entire gland. There is no established values to what's considered recurrence in these treatment options because it's difficult to distinguish because you're only treating part of the gland. So you will have residual normal tissue, which of course will generate PSA. So it's hard to come up with a criteria of what's considered biochemical failure or concern for recurrence. So the criteria for that is obviously under investigation at this moment. Local recurrence is associated with increased risk for metastasis, and without salvage therapy, average time to metastasis is 3 years. So this is an example of a patient who underwent radical prostatectomy. So there shouldn't be a mass there at all. In fact, we do see one here. So this is recurrence. What MRI also tells us is, unfortunately, he also has an enlarged lymph node, which is depicted by the red arrows. And also, unfortunately, the tumor has also spread and invaded into the anterior wall of the rectum, which sits behind here. So this is where MRI can show recurrence and the extent of the recurrence. Now moving on, going over this prostate PIRR assessment category. Again, the categories are 1 to 5, similar to Pi-RADS, with likelihood of recurrence increasing with increasing PIR score. So PIRR score of 1 is very low likelihood of recurrent prostate cancer to be present, moving up to a score of 5, where there's a high likelihood of recurrent prostate cancer to be present. Now, this only applies to patients who've undergone radical prostatectomy and radiation. It could be external beam radiation or brachytherapy. It does not apply to patients who've undergone focal therapy or patients who undergone androgen deprivation therapy, right? So this is a patient who underwent external beam radiation therapy. The images I'm showing are before the treatment, before the radiation therapy. You see that there's actually a tumor in the left side of the gland here. And post-radiation causes changes to the prostate gland that it makes the lesion or recurrence difficult to detect. You can see the peripheral zone usually is brighter. We talked about peripheral zone being brighter and the cancer is darker. After radiation, what's bright can be diffusely dark, and it makes the cancer very difficult to identify. And this is where contrast and diffusion-weighted imaging is helpful, because with the contrast, you can see that there's an area of enhancement, and this is in keeping with an area of recurrence. It's also important to keep in mind that recurrence tends to occur at the site of where the primary tumor was. So it's always helpful to have your pre-treatment imaging. Sometimes, often, we don't have that available, and we do use the contrast and the diffusion-weighted imaging to help identify for areas of recurrence. So this is suspicious for recurrence. It's giving a score of Pi-RR 5. This is a patient who had brachytherapy. And again, post-brachytherapy, similar to external beam radiation, can render the peripheral zone dark, and it makes it difficult to identify any residual cancer or recurrent cancer in here. It's really hard to find. However, on DWI, you can see that there's an area of restricted diffusion as a bright spot here and a dark spot here, and focal area of enhancement. So that is in keeping with recurrence. So when we use the PIRR chart, for the contrast, it's a score of 4 because you see focal enhancement, and then you see focal restricted diffusion. If you have 2 4s with this system, it gets upgraded to a 5. So this is highly suspicious for recurrent cancer, and this was biopsy proven. So you still need to biopsy confirm recurrence. You cannot just make the diagnosis alone on MRI. You still need to get tissue to confirm that there is recurrence. But at least helps to guide you with a targeted biopsy. This is an example of focal therapy. This is what a prostate gland could look like after there's been treatment, and this patient underwent high intensity focused ultrasound. So we used ultrasound waves to basically destroy the tumor. And as you can see here, the prostate gland predominantly is dark all the way around. And there's a focus here that demonstrates restricted diffusion. So bright on the DWI, dark on the ADC, and focal enhancement. Now, because you have focal therapy, you can't use the PIRR system. All you say is that there's an area of restricted diffusion enhancement, and it's worrisome for a site of recurrence. And this lesion was biopsied, and it came back as recurrent prostate cancer. Here's another patient who underwent high-intensity focused ultrasound. So in terms of focal therapies out there, there are actually quite a few. The one that's been most commonly used is HIFU. Ultrasound is the one that has obviously most research because it's been more readily available and more widely available and been around a little bit longer. So on TT, you can see the gland is quite small, and that's what can happen post-HIFU, and the lesion is dark. So the whole peripheral zone is dark, which makes it hard to depict cancer. And this is, again, where DWI, where you show areas of restricted diffusion, and on the ADC, and then you see the enhancement. So these 2 sites are suspicious for areas of cancer, and we did targeted biopsies confirming prostate cancer recurrence. So moving on to active surveillance. As we know, it's conservative management for low or intermediate risk prostate cancer. And the criteria for that is varied. It depends on institution, but most in general use a Gleason score of 6 or less. Sometimes small volume Gleason 7, like a 3+4 small volume. Clinical stage T1C or T2A, so the tumor is confined within the prostate gland, PSA level of less than 10, and PSA density of less than 0.15. And it's been shown to have excellent survival rates in these patients. With regards to follow-up of these patients, there isn't any established guidelines. We do know that often the patients do have what's called a confirmatory biopsy after the initial diagnosis. Excuse me. Anywhere from 6 months to 12 months. Again, that interval is institution dependent. And imaging, when to do that MRI, or if you're going to do that MRI, but most people do have that MRI, is variable as well. What the studies have shown, and we did kind of look at our own data a few years ago in patients undergoing active surveillance and looked at MRI, and we found that there was progression in about 24% of patients. We also looked at what happens in active surveillance when patients have their MRI. And we found that overall, the changes of the core index lesion is small. And sometimes new lesions did occur, but they did not alter management. So this is kind of some studies that we did within our own center. There have been other studies. This is analysis of 15 studies of over 200 2,200 patients with sensitivity and specificity as listed here. Sensitivity 59, specificity 75%, positive predictive value of 37 to 50%, and negative predictive value of 81 to 88% in terms of detecting prostate cancer progression during active surveillance. So they also found a progression rate in about 27%, so kind of similar to our data. So as you can see, MRI is helpful, but not perfect, but certainly room for improvement. So what they found in this meta-analysis is that if you use prostate MRI, you could actually avoid biopsy in over half the men. So 683 of the men out of 1,000 men would avoid biopsy if they had the MRI showing no progression. However, MRI is not able to depict all the cancers that progress, and that it did kind of miss progression in 124 cases. So the conclusion out of this meta-analysis was we can't rely solely on serial MRI, though it's helpful. Still need to look at clinical factors like what is the PSA doing, and certainly need more prospective large cohort studies to decide the most appropriate follow-up algorithm and interval for MRI and PSA. This is an example of a patient who had a regular systematic biopsy before the MRI, and the results showed Gleason 3+3. And he had the MRI before the confirmatory biopsy to help guide, because if there is a suspicious lesion, of course, you would target that at the time of the confirmatory biopsy. So we see the small lesion of 0.8 centimeters in the left mid-gland to apex region as shown by the red arrow. On T2, it's dark, a score of 4. On DWI, it's bright. ADC, it's dark, score of 4. It enhances, overall score of 4. So this patient went on to targeted biopsy and came back as Gleason 3+4. So this is a patient then went on to active treatment because we were able to identify a higher grade lesion in this targeted biopsy. And that's where active surveillance MRI can be helpful to help triage patient more appropriately, in this case, to have active treatment rather than active surveillance. With regards to active surveillance, as mentioned, there isn't any real formal guidelines at this point. This is more still investigational. There's a proposal, perhaps maybe we can use what's called a PRECISE system, which stands for Prostate Cancer Radiologic Estimation of Change in Sequential Evaluation. So a score of 1 to 5, 1 and 2 showing that there's resolution, complete resolution reduction of the changes that you saw on the prior MRI. A score of 3 means there's been no change on the MRI. A score of 4 would be some change, like the lesion has gotten bigger or more suspicious features, or a score of 5 would be definite progression, for example, a tumor that has then spread beyond the prostate gland and invading adjacent structures. And here an example in this article where we see this tiny lesion, you can see with the white arrows, and then the follow-up MRI, you just don't see it as well. So this would be a PRECISE score of 2. They also confirmed it with biopsy, and the biopsy was negative. Whereas this patient, over serial MRIs, you can see that the lesion is getting bigger. So it's on from 6.6 millimeters to almost 13 millimeters. And this would be a PRECISE score of 4, where you see progression. So just to kind of summarize where we are with active surveillance, MRI and targeted biopsies should be included, and most urologists are including an MRI in active surveillance patients. An MRI is able to identify clinical progression and trigger rebiopsies, as shown in that case where we saw that little lesion and the patient ended up having Gleason 3+4 and proceeded to treatment. As mentioned, in terms of formal interval guidelines, it's still unclear There's still research being done to decide, okay, how often should the MRI occur and exactly when should we be triggering the biopsy. There is data, though it's limited, suggesting that your serial control biopsies, because sometimes when you undergo active surveillance, you may be biopsying every so many years, that perhaps these biopsies can be avoided if the MRI and other parameters such as PSA density are stable. So that's some early data, which is good news because then it really avoids, repeated biopsies. But at this point, cessation of control biopsies is not recommended. And moving on to screening, what is the current evidence? There is limited research studies available at this point, but there are several prospective randomized trials that are underway. So hopefully soon we'll have some answers to this. Currently, so far, the science is showing us that the MRI-only approach is looking favorable. It's performing better than just taking the PSA level, okay? There is one study so far out there that was prospective, and they looked at patients who underwent an MRI, an ultrasound, and a PSA. And to summarize, what they found that patients with a Pi-RADS score of 4 or 5 compared to patients who had a PSA level of greater than 3 detected more clinically significant prostate cancer. And in addition, this was done without increasing the number of biopsies and also did not overdiagnose clinically insignificant prostate cancer. Okay. So that seems kind of promising. So screening with MRI, certainly has potential there. But things to keep in mind is it's a cost. Certainly MRI is going to cost more than a blood test for PSA. And availability is an issue. I know those of you who have undergone prostate MRIs already understand there is a bit of a wait list. So, availability is an issue compared to a blood test that's more readily available. And there is also differences in how we acquire the imaging and the interpretation. There is some variability. Even though Pi-RADS is available for standardization, there is still some variability. And right now, this is relatively early. We don't know the long-term impact on mortality by using MRI only as a screening tool. And obviously, there'll be a demand, right? Because every Canadian man will want an MRI, and rightly so, should be offered one. So obviously, how do we keep up with the demand, making sure there's available radiologists to read them and radiologists that are experienced enough to read them well? And perhaps this is where artificial intelligence, or some of you might have heard about this, may be able to come and help and kind of augment the work that we do as radiologists. So that's where we are with prostate MRI. We've come a long way in the last few decades, started from staging, moving to detection, and now monitoring post-treatment, especially post-radiation and post-prostatectomy, where we have standardized PIR system to assess. It's helpful also in monitoring in the active surveillance population. And now we're investigating as a tool for screening. So I want to thank you for your attention and happy to answer any questions.